Thank you everybody for joining us this evening for another great evening of the Animal Medical Center's One Health Conference. This is the Animal Medical Center's 6th annual One Health Conference hosted by the Ann and Charles Johnson One Health Institute. The One Health concept recognizes the connection between human and animal medicine and advocates a comprehensive approach to health and environmental problems. It aims to build bridges between physicians and veterinarians and public health professionals to promote, improve, and defend the health and well-being of all species. The Ann and Charles Johnson One Health Institute at the Animal Medical Center allows our veterinarians to continue to work collaboratively through interdisciplinary research to help advance veterinary and human medicine. For the past 6 years, AMC has hosted this One Health Conference to bring together professionals to learn and engage with topics that affect our approaches to both human and animal medicine so that we can learn from each other. This year, I was approached to ask if I was interested in hosting the One Health Conference, and of course I accepted. So the theme this entire week has been physical rehabilitation of chronic diseases. Every day this week, we have been presenting a new topic, and I'm going to go ahead and share my screen so that I can introduce our topic for today, which is the long-term management of osteoarthritis. I am so pleased to welcome this evening Dr. Kristin Kirkby Shaw and Dr. Jessica Hooper. Dr. Kristin Kirkby Shaw is a dear colleague and friend of mine. I am so pleased to welcome her this evening. She is double boarded in small animal surgery as well as sports medicine and rehabilitation. Her career has focused on bridging the gap between these two disciplines. Kristin has been a surgeon and rehabilitation specialist in Seattle since 2010. She practices at the Animal Surgical Clinic of Seattle and is the medical director of Sound Veterinary Rehabilitation Center, where she specializes in seeing dogs with hip dysplasia, elbow dysplasia, cranial cruciate ligament rupture, and arthritis. Dr. Kristin Kirkby Shaw is the past president of the American Association of Rehabilitation Veterinarians and is currently an instructor for the Canine Rehabilitation Institute, which trains hundreds of veterinarians in the field of animal rehabilitation. In 2018, she was the recipient of the John Sherman Award for Excellence in Veterinary Rehabilitation. In my opinion, she should have won the award 10 years ago. She is exceptional in the field of veterinary rehabilitation. She is a frequently invited speaker at national and international veterinary conferences and has authored numerous journals and articles and textbook chapters related to veterinary surgery and rehabilitation. Kristin founded CARE, the Canine Arthritis Resources and Education, in 2018 to provide valuable tools and resources for her clients and veterinary colleagues, as well as those caring for dogs with arthritis around the world. And I just want to give a big shout out for that website. I use it all the time, and it's a wealth of information. So for all of you in the audience, it is www.care.org, Canine Arthritis Resources. Hopefully I got that correct.
Caninearthritis.org.
Caninearthritis.org. Wonderful resource. So please hop on there, join as a free member, and there's also some other resources there for both clients and veterinarians. So a wonderful resource. And I'm going to go ahead and introduce Dr. Hooper too, and then we'll go into the individual talks. Dr. Jessica Hooper is an orthopedic surgeon specializing in hip and knee replacement. She completed her residency in orthopedic surgery at the NYU Hospital for Joint Diseases, followed by a one-year fellowship in joint replacement at Stanford University. Her research has focused primarily on patient outcomes after hip and knee replacement and application of new technologies such as 3D printing and virtual reality to arthroplasty surgery. She is currently working at Kaiser San Rafael in Northern California, and her practice focuses on primary hip and knee replacement, partial knee replacement, and complex revision of hip and knee replacement surgery. So welcome to both of you wonderful women who are leaders in our respective fields in veterinary and human medicine. And with that, I would like to pass it over to Dr. Kristin Kirkby Shaw for her presentation. Thank you.
All right. Thank you so much, Dr. Alvarez, and to all at AMC for the invitation and honor of being part of this. Any chance I get to be part of any sort of One Health initiative, I jump at the chance. So thank you so much for that. And I'm incredibly excited to listen to Dr. Hooper. I am also a surgeon in addition to doing rehab. And so I can't wait to hear what she has to share with us. So I will get through my portion as quickly as possible.
Kristin, give me 1 second. I am so sorry. I forgot to give a big shout out to our sponsor for this talk. This wasn't meant, thank you. This is not meant to be, we're a nonprofit organization, but PulseVet, who is an amazing organization, reached out and asked if they could sponsor because they saw the amazing speakers, in particular, Dr. Shaw. And so I do want to give a big thank you to PulseVet. PulseVet is a worldwide leader in regenerative medicine with products using shockwave technology to treat animal patients by reducing inflammation, increasing blood flow, helping bones to form and heal, and enhance wound healing. So thank you to PulseVet for your sponsorship this evening.
I will just echo what Dr. Alvarez said. Thank you so much to PulseVet. I use their product every single week, and we'll talk just a little bit about how shockwave therapy fits into the management of arthritis. And a few disclosures, I'm a consultant for a few different companies that play in the world of arthritis. All right, so anytime we talk about OA, we've got to start at the beginning. And I know actually Leilani talked about this last night, just the pathophysiology of canine osteoarthritis. First of all, it is the most common cause of chronic pain in dogs. And that alone makes it probably one of the most important conditions that we need to talk about, because chronic pain is one of the leading causes of euthanasia in our patients. So it's crucial that we get on top of this as early as possible. The estimate is that it affects upwards of about, around 50% of adult dogs. There was a statistic of 20% that came out in the 90s. And the more that we learn about OA, the statistic is probably close to about 50% of dogs. And the the pathophysiology is that OA is a vicious cycle between inflammation and degeneration in the joint. And there's a variety of different enzymes and cytokines and proteins and products that are involved in this process. I think historically we think about products such as PGE that we target with our NSAIDs, but there are a lot of different products out there. And Leilani mentioned this last night as well, if you were there for her awesome talk on supplements, that by understanding where all these different targets are, what all of the different mediators of inflammation and degeneration are, these are where we can actually start using some of our therapeutics to target these mediators of the process. The last thing I'll touch on is that OA is not only a local inflammatory condition, it's a systemic inflammatory condition. And I'll actually back up and clarify that yes, osteoarthritis is an inflammatory condition. This is an important thing that I think there's a lot of misconceptions out there. It's not a neutrophilic inflammation. When we do a joint aspirate, we sure don't expect or hope to get neutrophils on our aspirate, but it is still inflammatory. It's a chronic inflammatory situation. And a lot of it is regarding the synovium, the synovitis that's involved in the progression of arthritis. But again, local and systemic, and that's going to be really important when we talk about some of our therapies. But there's a question of why does OA develop in dogs? And this is what I'm really excited to hear about Dr. Hooper, because I think this is an area that dogs and people differ quite a bit. Because in dogs, osteoarthritis is almost always a secondary condition, meaning it develops secondary to some underlying abnormality in the joint, some abnormal biomechanical forces due to, most commonly, degenerative developmental orthopedic disease, such as hip dysplasia or elbow dysplasia, OCD, even medial patella luxation. Cranial cruciate ligament. We know cranial cruciate ligament rupture is the most common cause of pelvic limb lameness in dogs, and it will 100% of the time lead to OA. There's actually a debate of kind of chicken or the egg, which came first. Is there a synovitis that precedes degeneration of the ligament and then eventual rupture? But no matter what, if we have a dog with a CCL rupture, we 100% of the time will have OA associated with it. Dogs that have articular fractures, angular limb deformity, as shown in this picture here, obesity. We know 50% of our dogs out there and at least 50% of cats, you're not talking specifically about cats, but we have to remember them. Obesity is a huge problem, pun intended, and we know that that is a leading cause of OA in our patients. So therefore, OA is predictable. It shouldn't be this surprise to any of us when we have a 9-year-old Labrador that has had a known elbow dysplasia its entire life develop really significant limitations and mobility concerns later in life, because we should have identified that really early on in that dog's life. So diagnosis really starts with an index of suspicion. This is the time that I say it's okay for us to be breedist. We really should be. In my neck of the woods, we see a lot of Bernese Mountain Dogs with a lot of joint issues. This was Harley, and she had bilateral elbow and bilateral hip dysplasia. So we need to start with that index of suspicion, including our signalment. So we know those frequent offenders are Labradors, are Berners, Rottweilers, German Shepherds. Essentially, any of those breeds, you have to be looking for OA and be concerned about it. History, observation, we don't have time tonight to dive into all of those details, but it is important to really start looking for OA early, because once we identify those dogs at risk of developing OA as early as we can, and this picture here shows my lab when he was 4 months old, that's when I recommend starting to look for especially hip dysplasia, because there's a lot more things that we can do if we're proactive and we can intervene as early as possible in the disease process. And one of the most important things is actually client education. And so my guess is that most of the people on the call tonight are probably not primary care veterinarians. My guess is most of you guys are in the rehab world in some capacity, but especially if you're in general practice and you have these puppies coming in, this is the time. I know it's sad because I have to do this too, to talk to a client that has a young puppy. They're excited about the life they're expecting with it. You need to talk to them right then and there about all of the things that they need to do to keep that dog healthy for as long as possible. And that includes pain management, weight management, and activity recommendations, not restrictions. And so those are things I want to talk about tonight. Again, really trying to diagnose and intervene as early as possible. So when it comes to treatment, this is actually a summary of an article from the human side, so from the Journal of Osteoarthritis and Cartilage, which is the primary journal for the Osteoarthritis Research Society International, ORSI. And in 2019, they came out with guidelines for non-surgical management of knee, hip, and polyarticular arthritis. And basically what their core recommendations, no matter what type of arthritis it was, the main things they recommended were patient education about OA, dietary weight management, and a structured land-based program. And so I am looking forward to Dr. Hooper's take on this as it relates to her patients. But from our side, we don't have the equivalent at this point in time. We don't have guidelines really for many things in our veterinary world, but we don't have guidelines yet for saying what we should be doing for different types of OA. This is a systematic review that was published in 2012 in the Vet Record, and it's probably the closest we have to any sort of guidelines. And with a systematic review, again, for the sake of time, I don't have time to get into all of the details of this study, but a systematic review is really kind of almost the highest level of evidence that we can get, because it summarizes the evidence that's been already published. And so this publication came out and it reviewed articles published between 1985 and 2007. So obviously there are things that may have been missed that are more recent. They looked at 68 articles that reviewed 41 different therapies. Really the only thing that came out on top with high levels of evidence were the NSAIDs, carprofen, firocoxib, and meloxicam. There was moderate evidence for polysulfated glycosaminoglycan, which we know as Adequan, elk velvet antler, and a greenlet muscle-enriched diet. And then they concluded that there was weak or no evidence for electroacupuncture, shockwave therapy, hyaluronic acid, pentosin, and TPLO. And I should clarify, this weak to no evidence didn't mean that these therapies were shown not to work. There was insufficient research to show that they did, meaning there were not enough high quality trials or not enough subjects or not enough dogs in the individual studies to bump it up to a high level of evidence. So again, Doesn't mean these therapies don't work. It just means we don't have the research yet to support it, or at least at that point in time. This was an article that I wrote as part of my PhD, and it was also a systematic review looking specifically at the evidence for non-surgical management of canine hip dysplasia. And we reviewed 14 articles and 6 different therapies. And unfortunately, there were no level 1 studies. So meaning the top of the pyramid, the highest level of evidence, we didn't have anything out there to look at this. But the conclusions we came up with based on the evidence that we reviewed was that weight management was the most important thing, or is the most important thing based on the evidence for managing OA associated with hip dysplasia. We'll talk a lot about that. We also found that polysulfated glycosaminoglycan, again, Adequan, shockwave therapy, and stem cell therapy may be beneficial based on some level 2 and level 3 studies. And then activity restriction, acupuncture with gold beads had the lowest level of evidence. So again, those things weren't supported as treatment methods for canine hip dysplasia. So what does this mean in a practical sense? I think we should be guided by the best available evidence, but what does it mean when we're actually talking to clients and putting together a plan? So this is my personal way that I categorize my treatment plan when it comes to developing an OA plan for my patients. And this is in order to keep me organized and systematic as I talk through all of the different potential treatments. Now, again, for the sake of time, I don't have time to get into every single one of these. And especially I'm not going to talk about surgery because the title of this talk and this week is non-surgical or physical rehabilitation techniques. So I just want to get into a couple of the most important that I believe that we all should be doing, no matter if we're kind of icing the cake with our others, whether it's needle therapy or laser therapy, some of the basics that we should be doing for all of our OA cases. So pain management, first and foremost, again, I said at the very beginning that OA is the most common cause of chronic pain in dogs. And it's our obligation to manage that pain. And based on that systematic review, the thing that has been shown time and time again to be the foundation and the best method of pain management are our NSAIDs. Now, again, not enough time to get into the pros and cons of NSAIDs. Certainly not going to talk about the individual ones here, but I strongly believe the NSAIDs are the foundation of pain management. Now, obviously, there's times we need to either add or substitute with other pharmaceuticals, and I'm happy to take questions on these at the end. But for the sake of time, we'll move past this. I also I use Adequan. Honestly, in every single OA case, I'm recommending Adequan unless there's a contraindication for that. Intra-articular therapy, I actually do use quite a bit of intra-articular therapy, and I'm really looking forward to Dr. Hooper's thoughts on how that fits in the human side. I don't personally do acupuncture, but a few of my colleagues in my practice do, and so I know that can be beneficial for their patients. And then there's all of our rehabilitation techniques. Again, I do use shockwave therapy, laser, pulsed electromagnetic field, manual therapy, but again, for the sake of time, not going to get into the details of all of those. So we have to talk about weight management. So on the human side, on the veterinary side, obesity and weight management are the crucial, most important parts of managing OA. We know that obesity leads to OA. It makes OA worse. It compounds that pain because of that systemic inflammation. And again, in our patients, this ultimately leads to death or euthanasia. So it's pretty impossible for me most of the time to do an OA talk and not talk about the Purina lifetime study, especially when we're talking about lifelong management of OA in dogs. So hopefully most of you guys out there are familiar with this study, but what it was is it looked at dogs, Labrador puppies at the time, that were genetically predisposed to developing OA. And they were divided into 2 different groups. One group that's shown on the left here was a restricted fed group. The control fed group was fed 25% more in terms of calories than the restricted fed group. And these dogs were followed for their entire life. So these were research dogs. They were not client-owned dogs. So the only intervention was caloric restriction. And what they found was that there was a lower prevalence in OA in restricted fed dogs. And again, these are genetically equivalent dogs, all predisposed to developing OA. But just by restricting the calories, the dogs that were this limit fed at 8 years of age, only about 10% of them showed radiographic evidence of OA in their hips or shoulders, where almost all, 68 to 77% of the dogs that had this control fed had radiographic OA. And for any of you guys, certainly that own a Labrador, if you've ever met a Labrador, this is not an obese Labrador. This is a 6.5 out of 5, 6.5 out of 9 Labrador. So this is actually not as bad as most of the cases we see. So the other big take home from this study was that the limit fed dogs lived on average 2 to 3 years longer. So when you have the opportunity to talk to that client with a dog that's diagnosed with hip dysplasia or any sort of dysplasia or joint disease as young as possible, and you say, what can we do to change this dog's life span and their ability, their disease, their predisposition to disease, the only thing that's been shown to really change that is caloric restriction. So we want to aim to keep these dogs on the skinny side of normal. That is a 4.5 out of 9. So weight loss, weight management should be, we've got to treat pain and manage that, but we also have to tackle weight loss. And again, I'm not a nutritionist. Dr. Wachslag did a fantastic job on Monday night talking about the veterinary nutrition side of things. So this is my take to talking to clients about weight management. Number one, make sure pain is managed. So we figure out the body condition score. I used 1 to 9. What's ideal? So we want to establish that ideal body condition, which is around 4.5. And so if we have a dog that's, let's say, 7 out of 9, that dog's going to be 20% overweight. So any increment over 5 is going to be equal to 10%. Then we do the math. And I am not a numbers person, and I'm going to show you a trick here in a second to get past that. But one thing I do want to highlight is I think it is crucial as veterinarians. So those veterinarians on this call, it is our job, if we're talking about a weight loss program, you have to recommend a specific diet. If you just say your dog needs to lose weight, the clients are not going to be compliant. So you have to tell them how many calories to feed them and what type of calories. So where are those calories coming from? What type of food should they feed, and how many calories do they get from treats? We need to give specific exercise recommendations and then follow up regularly, and that's going to help with our accountability. So on the caninearthritis.org website, we have a variety of different tools that, as Leilani mentioned, I use this every single day in practice, and all of my associates have this on their computers. Our technicians have it. You download it. It's an Excel spreadsheet where you plug in the body weight, you plug in the body condition score, and it does the math for you, and it tells you how many total daily calories the dogs need, and then it splits it into how many calories from food and how many calories from treats. And then this bottom yellow box here, if you plug in how many calories you know per cup, it will tell you how many cups to feed each day. So that's a really cool tool that we've got available on the website for you. So just in case you were wondering, some of our more common treats are very high in calories. I had a case just this week, where the clients were feeding one marrow bone every day. And this dog, when I calculated this dog's caloric requirement, she actually needed 768 calories as her total daily requirement. She was getting more of that just in her marrow bone. So be aware. All right, exercise and OA. Diet and exercise, the most important foundations for managing OA. On the human side, it's the most recommended non-pharmaceutical treatment for OA. And again, I'm looking forward to hearing what Dr. Hooper has to say about that. And there's a high level of evidence, meaning there's lots of research out there to show that exercise helps decrease pain in humans with OA. Now we, spoiler alert, we don't have those same degree of studies or level of evidence in our veterinary patients, but we have a couple that I'll highlight here. And this was a really cool study that came out a number of years ago, and I feel like it's kind of flown under the radar, and I don't hear a lot of people talk about it, but it was a prospective case series looking at Labradors with hip dysplasia. And they divided them into 3 groups, basically. Those dogs that exercise for 20 minutes or less every day, those exercise from 20 to 60 minutes every day, and those that were over 60 minutes every day. And then they also they looked at the type of exercise, whether it was low impact, and low impact was either walking or swimming, or high impact, which was anything else, including running, jogging, hunting, field trial. And what they found was that the only thing that was associated with decreased pain and improved range of motion in joints was walking longer than 60 minutes. So it actually didn't matter, and this was shocking to me, it didn't matter the impact or the level of activity. It was just that more exercise was better in these dogs. So exercise was associated with this, with a decrease in severity of lameness in dogs with hip dysplasia. So what do I recommend? The most important thing that I recommend is this regular exercise. So going for a walk, ideally every single day. Now in COVID times, that really doesn't seem to be a problem. Sometimes we're having to rein our clients in a little bit, but regular, controlled, and I'm talking about kind of OA in general here. I still do recommend controlled, especially for our elbow arthritis dogs, meaning the opposite of controlled is a dog park. So a leash walk is really the thing that I'm talking about. It's controlled. And then ideally low impact, but the question mark is if we have a dog with hip dysplasia and hip OA, if that's all we're dealing with, perhaps they can engage in those high impact activities as long as they're doing something every day, and more exercise is better. To me, I'm still generally recommending this regular low impact and controlled. And then incorporating therapeutic exercises into their daily routine. So this video here is showing my husband taking our dog for a walk, and every time they come to a stop, a crosswalk, he has to do a sit to stands. So we get, he gets about, 20, 30 sit to stands in the total time of that walk. So just trying to incorporate exercises into something that the clients are already doing. And so what about walking in water? All of us, well, not all of us, many of us that have a rehab center, we're using underwater treadmill to treat our patients. Has there been any research to show? Well, we don't have great research with underwater treadmills specific to OA, but there was one study I came across looking at one single hydrotherapy, and this was actually swimming, not underwater treadmill, in dogs with elbow dysplasia. And they found that by just doing 20 minutes of swimming, when they measured 10 minutes after that swim session, the dogs had improved range of motion in their elbows. They looked at both normal and dysplastic dogs, and both dogs had improvement in their range of motion, even more improvement in the dogs that had limited range of motion to begin with. So we can't extrapolate to the underwater treadmill, but hopefully somebody will do that study sometime soon. So the last thing I want to touch on is environmental modifications. And I think this is something that as a profession we forget about, and that is how to tell the owners to set up their home. And I have learned so much about this in these ages of COVID, and seeing inside people's homes, whether it's doing a Zoom call or if they're sending videos to us. So it's really important to make sure that the home is set up as best as possible for their arthritic dogs. So first you've got to understand, what does the dog need to do in their home environment? Do they have to do stairs? If they have to do stairs, we have to figure out a way to make that easy on the dog. The other things that I find that are very helpful are the idea of this raised food bowl. So this is Beans. She's my Frenchie. She's 13 and a half at this point. She has horrible hip dysplasia. Hip dysplasia is near and dear to my heart and my dog's. So she's also paretic, has some pelvic limb paresis at this point, but by shifting all of her weight, if her food bowl's all the way on the ground, she has to shift all her weight to her front legs, and she's not really using her back legs. So if I elevate the food bowl off the floor, it's helping neutralize her spine and shift weight to the back legs. It can help strengthen them. This is really important for dogs that have elbow arthritis or carpal arthritis, because the more if their food bowl's on the floor, they're having to bend down, that's putting a lot more pressure on the front leg. So just elevating the food bowl. And so the last thing I just want to close with is a case example. This is Pickles. She's a 9.5-year-old female spayed lab. She's a crisis response dog. So she's called out to all sorts of awful events that occur. If there's a school shooting, there was a giant mudslide here a number of years ago. She goes out there and she's the dog that people hug when they're crying. And I met her when she was about a year old, and she came in with bilateral elbow dysplasia and unilateral tarsal OCD. And the owners are amazing. They're incredibly proactive. So they wanted to do absolutely everything. So we actually started mesenchymal stem cell therapy on her at the age of 1, along with everything else I've talked about, NSAIDs. She's on a variety of supplements, regular exercise. These clients are so dedicated that they moved to the lake so that she could swim every day. And they've done this kind of extreme home makeover. And I just emailed them asking for pictures so I could share with you guys. And it's been interesting because here's what we're seeing. So they carpeted the stairs, which is awesome. That's fantastic. She has to do the stairs. And they're very, she said, we've got carpets everywhere. Well, when I see these pictures, and I've cropped them for you, I see a lot of hardwood floors. So I would personally love to see a lot more carpeting and a lot more yoga mats covering the floors, but at least there's areas where she can have the rug. But the times that you really need those rugs are right when they're coming down the stairs, so they're not slipping and sliding. Over here is the raised food bowl, but I would like to see a rug here. Maybe she's okay at this point, but eventually she may need a rug there. I would move this rug closer to the crates, so when they're coming out of the crate, there's something to get grip on. And then the last thing is they installed artificial turf on their deck, so she didn't have to go down very steep steps when it was wet outside. So that was a lot of dedication, and probably most of our clients aren't going to do this, but just want to kind of hammer home that it's really important to talk about those home environment modifications with your osteoarthritic cases. So really, that's it for me. OA is predictable in dogs. Look for it early and come up with a comprehensive plan. Must include weight management, weight loss, must include regular activity, must include pain management, and home environment modifications. So with that, if you want to follow up, send me questions, info@caninearthritis.org. And with that, I can't wait to hear Dr. Hooper's talk.
Amazing. Thank you so much, Kristin. I think everybody would agree that whenever we hear you speak, we have so much practical information backed by scientific research and is just at our fingertips. So I always learn something when I hear you speak. Thank you so much for that wonderful presentation. And with that, I'd like to welcome Dr. Hooper. And if you would like to share your screen and give your presentation, thank you.
Great. And thanks so much for that awesome talk, Kristin. That was awesome. All right. Okay. Good evening, everyone. Thanks so much for inviting me to talk to you tonight. I'm really excited to be here and to be speaking with you. I do not have any disclosures to share. I would like to acknowledge Derek Monotula, one of my mentors, for some of the slides that I used in this talk. And then I did also want to just say that I'm going to focus primarily on knee arthritis tonight. It would be really comprehensive to get into hips and knees because there's a lot of different treatment options for both. So we're going to just stick with the one joint for tonight. All right, so like we heard already, arthritis is one of the most common chronic conditions, and it affects greater than 50 million older adults in the United States. Over the past 25 years, we've seen that prevalence increase by 40%. I think that's probably in part due to people being active later in life, and just that our population as a whole has been aging. Arthritis is the #1 cause of disability in the United States, and it imposes a huge cost on the healthcare system, up to $127 billion per year and $2,003 to treat. As we know, there is no cure for osteoarthritis, and the cost is so large because it is a lifetime management type situation, whether the patients are having surgery or not. Talking about why do people get arthritis, it's unfortunately a bit less predictable than it is for dogs, like we just heard. But I think it's always important to take a look at someone's the alignment of their legs. So we get weight-bearing X-rays to provide a static snapshot of the limb position and alignment. Sorry, please excuse the cat. A normal femoral tibial angle is usually defined as 6 degrees of valgus. In the normal hip, knee, and ankle axis ranges from 5 to 2 degrees of varus. Any deviations from this neutral for the patient will create a moment arm that will either overload the medial or lateral compartment of the knee, depending on which direction it's in. And it's interesting is that most discussions of alignment in knees do not really focus on the hind foot or ankle position, which obviously can have a huge impact on how a person stands and what their overall alignment is. This study was done a couple years ago by the orthopedic group at University of Iowa. Their goal was to better look at how the hind foot compensates for limb malalignment in patients who already have advanced knee arthritis. And they found that the hind foot compensation for any deformity at the knee is primarily at the subtalar joint. And it's usually opposite. So if someone has severe varus at the knee, varus alignment and arthritis, the hind foot will shift into valgus to compensate. The opposite is true if someone has valgus alignment and severe arthritis. This is kind of interestingly the opposite of what we see if someone starts with bad hindfoot deformity and arthritis and then goes on to develop knee damage as a result of the way that they're standing. So I would say that alignment can definitely predispose to knee arthritis, but usually an injury does also have to occur. That can be, and I think is most common for our patients, is a chronic overloading type situation, whether that's due to a job or to a sport that they're really active in. There is often also an acute injury like an ACL tear or a fracture. And then also, usually when we're thinking about injuries that can affect the knee, we're thinking about things that happen directly to the knee, obviously. But I think it's also worthwhile to mention too that some people that have bad injuries to their hips or their ankles or foot can affect the knee secondarily by the way that patients bear weight through the knee and what they, how they change their gait and body position to compensate. So, the treatment of arthritis is an art in humans, I would say, and it can be very frustrating for both patients and providers to manage because there is, that often the x-ray doesn't exactly match the symptoms. We see this x-ray here, this patient has, I would say moderate to severe arthritis of the knee, primarily in the medial compartment. You can see that on the left side of your screen. But, the treatment options for this patient depend on their age, patient's age, the level of the pain that they're having, their activity levels and goals, and also, and just as importantly is their medical comorbidities and their overall health situation. So unfortunately, there is no one size fits all treatment. It's definitely a balance. And in counseling patients, I try to make them aware that we're trying to balance the risks and potential side effects related to operative and non-operative treatments, and to get them, to where they want to be with their health goals. Honestly, I think a lot of it comes down to timing, really how bothersome are the arthritis symptoms, and given everything else going on in their lives and their health, what treatment makes the most sense for them right now. So I, including these learning objectives just kind of to guide us, it looks sort of like fence posts as we go through this talk. So, my first one is that the management of mild to moderate arthritis in humans involves pain control and maintaining range of motion, number one, to keep them as active as they can be. The most important non-operative treatments are lifestyle modifications, and they truly do affect the way that we load our joints. So, I like this table because it shows the differences in loads borne by the knee during different activities. The low impact exercises that are outlined in the green there, like walking and biking, obviously swimming should be on there too, but it just was not, included in this study. I like to recommend them for my patients because they don't overload the knee, and actually they do allow them to build and maintain strength in their legs without, putting too much of a demand on an already damaged or painful knee. The higher impact exercises and activities seen in the red box there do generate huge forces through the knee. And I think it's also important to see in that middle column, the percentage of body weight that is involved, just how much of an impact weight loss can have on the load being borne by the joint. So, speaking of weight loss, like Kristin said, it's hugely important and is the strongest recommendation from the American Academy of Orthopedic Surgeons for treatment of knee arthritis is weight loss. This is a meta-analysis from 2007, which showed that, effective pain reduction was seen, although the amount of pain reduction was not always predictable after weight loss. The regression analysis did show that physical disability of overweight patients with knee arthritis did diminish after a moderate weight reduction regime. And what that meant to them was that losing at least 5% of body weight within a 20-week period. Obviously this is can be a very touchy subject for many of my patients. There's a lot of, components that go into weight loss and being overweight and activity levels. So when I talk to them, I try to focus on how even small amounts of weight loss, 5 pounds, 10 pounds, can substantially reduce the load that their knees are having to bear, just doing normal everyday activities. Also, if I am having a conversation with someone about doing a joint replacement, I do, find it important to mention to them that the risk of complications goes up substantially with being overweight, specifically a BMI of 35 puts them at a very high risk of a post-op infection, and that risk goes up 8-fold compared to a patient with a normal BMI if the patient's BMI is greater than 40, so the morbid obesity class. We do sometimes offer, bariatric surgery to patients. Obviously not that we're doing it, but referral to our general surgery colleagues for that. But I think our evidence is not really great for when to do it and how much it helps, because there's a lot of different types of bariatric surgery without getting into the weeds too much. Some of them do produce nutritional deficiencies that occur as part of the way that the weight loss happens, but they require the patient to have close follow-up and close supplementation, which is not possible for everyone. And sometimes these patients, even if they have lost weight, when we do see them in surgery, their tissue is very poor quality, and that also raises a lot of concerns about wound healing and therefore infection risk. So I would say for bariatric surgery, the jury is still out on how to use this as a tool. Cane use, I do think is also a helpful tool for patients with knee arthritis. I think there's definitely an ego issue at play sometimes with this, not wanting to feel like a person who needs a cane. But I do think it is an effective way to offload the knee. The study showed that VAS pain scores are substantially lower with cane use. This is attributed to reducing gait velocity, cadence, and the peak vertical ground force going through the knee. Interestingly, this study also showed that these effects are seen no matter which hand the cane is put in. So it can either be in the same ipsilateral hand as the affected knee or the contralateral, and it does work well. Medications are also a mainstay of arthritis treatment. Okay, sorry. Glucosamine and chondroitin, which are often taken together, are popular supplements that I think are marketed directly to patients and are very popular in patients who come into my practice. My parents have taken it. They say it helps them. The early studies that we had about this formulation showed that there was a moderate to a strongly positive effect in pain reduction for patients who took it. But I think overall there were a lot of issues with study quality and publication bias. So a more recent study demonstrated that an increase in treatment effect was seen for glucosamine and chondroitin. It was stronger when taken together, and it was better after a longer duration of treatment. However, it was not noted to be any more effective than just taking NSAIDs. And so our current clinical practice guideline from the AAOS says that there's essentially no evidence that minimum clinically important outcomes have been achieved compared to placebo for glucosamine and chondroitin, either alone or in combination. So they do not recommend it due to a lack of effect. Anecdotally, it's not a harmful medication at all. So if I have a patient who's taking it and feels like it helps them, I certainly don't have a problem with them continuing to take it. Tylenol is another medication that commonly is taken by patients with arthritis. There's even a Tylenol arthritis formulation. This was a meta-analysis from 2015 that demonstrated a stronger pain relieving effect with Tylenol compared to placebo, and that the effect of pain relief of Tylenol was similar to that was observed with NSAIDs. However, our AOS practice guidelines do give an inconclusive recommendation for Tylenol. And I think these guidelines were updated in 2016. And I think around that time, the RDA for humans for Tylenol decreased from 4 grams to 3 grams per day. Did that have an effect? Possibly, who's to say? I sometimes find that one will work better for patients than others. They'll find that Tylenol works better or NSAIDs works better. So I do use them, recommend them interchangeably, and also often for them to be taken together as well. NSAIDs, like we've heard, already are obviously a mainstay of arthritis treatment. This was a meta-analysis from 2004 that found that they reduced short-term pain slightly better than placebos, but the study did not support the long-term use given the risk of serious adverse events. Despite that, for the majority of patients, it is still given a strong recommendation for use. And I think the patients who have contraindications to taking NSAIDs are more the exception than the norm. So in my practice, I do find topical NSAIDs to be very hit or miss. For those patients who do have contraindications for systemic NSAIDs, they've had GI, cardiac, or renal comorbidities that are serious and that do preclude them taking oral NSAIDs. Sometimes topical diclofenac can be a good option for them. This meta-analysis did demonstrate that there was a greater pain relieving effect compared to placebo with topical NSAIDs. I find that my patients who like it really like it, and they swear by it and say it's the best thing ever, and the other half are like, I didn't really notice it was any different than lotion, basically. Narcotics, they continue to be a really hot topic. Opioid pain medications do get an inconclusive recommendation from the AOS. For years, tramadol was recommended for arthritic pain, but there's been several more recent studies that demonstrated similar treatment effect with tramadol and diclofenac, and no, clinically important difference seen with tramadol use. And so because of that, and because of all the many potential adverse events that can occur with taking opioids, including addiction and overdose, the recommendation is no longer in place for giving tramadol. And additionally, I don't prescribe it for my patients, especially those who are potentially surgical candidates, because it does make postoperative pain control substantially more difficult. So if they're already taking it, try to have them decrease before going in for surgery. Probably most importantly, the most effective way to use oral pain medications is in a multimodal strategy. There is a substantially stronger effect on pain relief with multimodal therapy than with any one of these medications alone. And we do this in the postoperative period after joint replacement surgery as well. So I am a big proponent of, kind of trying to hit the problem from all sides and using multiple drugs so that by their powers combined, they can have a better effect on controlling the pain. Injections are definitely an important part of the overall treatment strategy. There have been multiple studies that have shown a positive effect on pain relief from corticosteroid injections, and they are a mainstay of treatment for both hip and knee arthritis. But I do think, and we'll talk about this a little bit, that there are definitely risks associated with corticosteroid injections. And I think that, patients should be made aware of this before they have the injections. So, like I said, multiple studies have shown a positive effect on pain relief with corticosteroid injections. But over time, most patients do see a diminishing effect from the injections. In my practice, I try to use it pretty judiciously. So really saving the injections for when the knee is really angry and flared up. Perhaps if a patient with knee arthritis has fallen on their leg or had a twisting injury, I think you get the best effect that way. And then it also, kind of saves them from getting perhaps prematurely on the every 3-month train of getting the injections and having them lose their effect quickly. So like I kind of alluded to, this is something that's also been in the lay press a lot lately. You can see this is NBC News. This was from the fall of 2019. And patients are aware that, corticosteroid injections may be harmful. This study that they quote in the NBC News article found that 8% of the patients who got corticosteroid injections had joint-related complications 2 to 15 months after the injection, and these were defined as accelerated cartilage loss, which is something that I think multiple studies have shown over time that these injections can cause cartilage thinning. But the other ones were stress fracture, bone erosion, and joint destruction. So these are real risks. And I think that it's especially important to have the conversation with patients who have more mild or early arthritis, because accelerating their joint destruction has a much more substantial effect than someone who already is in the, classified as severe arthritis. Not that it doesn't matter for them, but they have less to lose in a way. So another type of injections are the hyaluronic acid shots or gel shots. This is Supart, Synvisc, that family. So hyaluronic acid is one of the chief components of the extracellular matrix and contributes to cell proliferation and migration within the joint. Viscosupplementation or HA injections work by providing lubrication and cushioning to the arthritic joint in theory. Multiple studies that were done, initially the ones that came out were industry sponsored, and they were, on a closer look, were of rather low quality. And so there hasn't really been a good quality study that has showed a large effect compared to placebo injections. And compared to corticosteroid injections, this was a 2009 meta-analysis that showed mixed effects with viscosupplementation. Each of the studies that were included in this analysis did not say how strict the criteria was for injection. So did they give viscosupplementation to people with all types of arthritis? Did they only give them for mild arthritis? But in my opinion, I do think that it can be effective for patients with early knee arthritis. But I wouldn't offer it to a patient who is in the, close to or already at bone on bone. And I do think that even in the patients with early arthritis, I have seen that the effect is less predictable. So perhaps one of the most important learning objectives of this talk is that despite what may be popularly reported in the media, we do not have any high quality studies that support using stem cells or PRP or other biologics for the treatment of knee arthritis. PRP or platelet-rich plasma is a sample of autologous blood with platelet concentrations above baseline values. Platelets play an important role in the normal healing response via local secretion of growth factors and recruitment of reparative cells. So the idea behind the treatment is that by injecting platelets, a high concentration of platelets into the site of damage, such as the arthritic knee, it will simulate and accelerate a healing response and regeneration. So again, similar to the viscosupplementation, most of the early studies were industry driven. This is a meta-analysis from 2013, which demonstrated no significant effect favoring PRP over a control placebo injection. More recent high quality studies have not yet demonstrated any effect for treating knee arthritis. As an aside, their best evidence for using this in orthopedic practice is for tennis elbow. And there have definitely been studies that have shown good response to treatment using PRP for that. So what about stem cells? Although articular cartilage is not able to repair itself, we do know that it has been found to contain a population of stem cells or progenitor cells that are thought to be involved in maintaining tissue homeostasis. These cartilage-derived stem cells or progenitor cells are multipotent, and concentrations have been found to be higher in knees with more advanced cartilage damage. So, theoretically, this is a good, potentially a good opportunity for a therapeutic. But I think that there's been a great disconnect between the regenerative potential that has been seen in the lab and what has actually been seen thus far in human trials. One of the big problems with this, the whole kind of biologics movement in orthopedics, is that there's really a lack of standardization among the researchers regarding cell preparations, terminology used, and treatment applications, which really contributes to the confusion, for both patients, practitioners, and the public. And I think it most importantly highlights that we really don't know how yet to use this treatment effectively for arthritis. Perhaps what's most concerning of all, though, is that there's a lot of misinformation out there. This is taken from a study that was published earlier this year in Journal of Bone and Joint Surgery, which is our most prestigious orthopedic journal for the U.S. And it showed that more than 95% of medical practice websites contain that offer a so-called stem cell treatment in their practice. Contain at least one statement of misinformation targeted to patients regarding the effectiveness of these treatments for a variety of ailments, including arthritis. Looking at this, some of this is kind of wild stuff. So, no longer do patients have to undergo barbaric orthopedic surgeries and weeks of painful rehab. Things that are just plain inaccurate, such as depending on the different tissues that are damaged, stem cells can turn into whatever is needed, can often be a combination of cartilage, ligament, tendon, bone, or muscle. And the results section too, just saying that 100% of recipients have no pain at 4 years. There's no study that's been published that has shown that. So this is what patients see when they look at websites with their knee pain, and they kind of get sold essentially by these statements. It's an attractive thing for patients to potentially not have this quick fix treatment rather than potentially go through a surgery and a rehab, or manage their pain, which would affect their lifestyle. And I think in a somewhat cynical way too, because these treatments are unproven, patients have to pay out of pocket for them, so there is sometimes a financial incentive at play as well. So I think it's really the responsibility of every physician to make sure that patients get true and realistic information about what our current evidence is, and what we know about the efficacy about these stem cell treatments. And who knows, in the future, I hope that we have better data and they do become a realistic treatment option, but we're definitely not there right now. So again, back to this, striking a balance. When is it time for total knee replacement? I usually tell patients that no matter what their x-ray looks like, they shouldn't consider it until their pain goes from being an annoyance to being a life-altering problem. So for example, having trouble climbing stairs, not able to do their work, trouble putting on shoes, things like that. Despite the claims of some of those websites that we just looked at, total knee replacement does alleviate pain, restore function, and improve the quality of life for patients with end-stage knee arthritis, but it should be considered a last resort option. There are several surgical options for treating knee arthritis with varying indications and success rates. Arthroscopy, I think, used to be done more commonly as a clean out surgery, so-called clean out for people with milder arthritis. We don't really do this anymore. It's ineffective and also can cause worse pain and accelerate the joint destruction. High tibial osteotomy, so offloading the affected part of the joint by doing a realignment surgery, sometimes is a good option for very young or very active patients who wouldn't tolerate a joint and knee replacement very well. So this would be, a 40-year-old laborer who only has arthritis on the inside part of their knee, or medial part of their knee. Unicompartmental arthroplasty, which is replacing only one of the compartments of the knee. I think, unless you happen to be within a referral practice specifically for these surgeries, that usually ends up being about 10% of the patients with knee arthritis are candidates for this. So having damage only in one part of the knee and the other two compartments being relatively pristine. Patellofemoral arthroplasty is kind of an unclear role in its effectiveness for pain control. There's actually a movement in full total joint replacement, total knee replacement, to not resurface the patellas. So it's kind of unclear if people do that and patients get good pain relief. What exactly does patellofemoral replacement accomplish? So it's kind of unclear. Total knee replacement is the gold standard still for the vast majority of patients with knee arthritis. And bilateral knee replacements can be done, but it's, I would say, only in select patients. It's obviously a longer surgery, so more anesthesia time, more potential for complications, though they are additive. it's the same infection rate. It would be the same for having 2-stage knees rather than exponentially greater. So, joint replacement surgery, like I said, the goal is to alleviate pain, restore function, and improve the quality of life for patients with arthritis. The number of total knees being performed annually is increasing exponentially, and with it, the cost to the healthcare system for caring for these patients. 3.5 million primary total knee replacements by 2030 is a humongous number. There are substantial risks with knee replacement, and that's the reason why I think it should be offered judiciously, because it is a major surgery, even though it is done so commonly now. We want the potential benefits to be worth the risks. It is a great option to getting patients back to what they want to do. And we do try to medically optimize these patients as much as possible, which helps lower the risk of adverse events. You can see the guy on the left, the thinner guy, he's at substantially lower risk of all types of complications than his counterpart on the right. And some of those, include subjective perception of how their knee is. There's a, I think about a 85% satisfaction rate after total knee, which is substantially lower than what we see for hip replacements. There's a lot of reasons for that, but I think a lot of it also has to do with patient expectations going in, and what they're expecting to be able to do, because this is not your 20-year-old knee that you have back again. So, I can't tell you how many times I see a patient who says the top quote, I was told I have arthritis and I need a knee replacement. I always tell patients that it doesn't really matter what the x-ray looks like if the joint doesn't hurt, because it's really hard to predict when and by how much someone's arthritis may progress, and how much their symptoms may worsen. I also feel it isn't really my place to talk someone into surgery, so I present the options and ask if they feel ready. I do think patients do better if they go into surgery having made the decision themselves, obviously with guidance and really understanding the risk-benefit trade-off and what they can expect after surgery. And that is all I have for tonight. So thank you very much for your attention. I really appreciate it.
Thank you so much, Dr. Hooper. That was an amazing presentation, and I certainly learned so much, and I'm sure that Kristin has a lot of questions for you. I have a lot of questions, but I want to give Kristin an opportunity and for the two of you to ask each other questions. We have a lot of participants still on, so even though we are over time, I think everybody is very interested in hearing the discussion. So Kristin, I'd like to give you the opportunity to ask questions, and then I have some questions, and there's a lot of questions from the audience as well. Thank you.
Yeah, Jessica, that was awesome. Thank you so much. I have, as Leilani said, a lot of questions, but my first one is, how involved are you as an orthopedic surgeon in the long-term management of your patient's arthritis? So they come to you, they're diagnosed with OA, and you talk to them about a joint replacement. Are you the one prescribing the NSAIDs and whatnot, or do you say come back when the knee replacement is needed?
I think it depends a lot on what your practice situation is for me. So for me right now, with Kaiser, a lot of the early arthritis management is borne by the primary care doctors. So they're the ones that make the diagnosis and really are, doing, talking to patients about lifestyle modifications, prescribing NSAIDs, and physical therapy, canes, stuff like that. Sometimes I do get them early sometimes, and in which case I really try to give them kind of the 50,000 foot view of arthritis and what to expect down the road. But often I'm not usually the first person that they see.
That's what I would have expected. Cool.
Yeah.
Can I ask one more quick question?
Sure, go ahead.
So this is a question I get all the time. The use of NSAIDs, do you or your colleagues recommend daily use or as needed?
Yeah, so my preference, especially if someone is in like a kind of a flare, or their joint is particularly angry, I will say to take it daily, regularly scheduled, at least for 2 weeks, if not longer. And then after that, as the symptoms go down, they can decrease to a more, as needed basis. I do like meloxicam a lot, and that is my favorite NSAID to prescribe. So, and the reason for that is because it is a once a day. So I think for my patients who have more severe arthritis, I do recommend that they just take it and stay on it. Usually it's pretty well tolerated too. So yeah. What about you? What do you say?
I prefer them to be on it for some period of time, at least a month. Usually I try and get 3 months. And then I'm hoping that in that 3-month period, we've gotten some weight loss. We've gotten Adequan works really well in our patients. And we've done some of the other things to then potentially consider reducing the frequency. But the problem is I don't think we're very good as pet owners at recognizing the flares. I think we can predict when there's heavy activity, but there may be these other flares that we don't recognize. So when in doubt, I try to keep people on it, on a long-term basis.
Yeah, definitely.
Interestingly, I'll just chime in on that because something that I offer to clients is the systematic review that was published by Ines. I think it was 2013, I want to say, in Vet Record, that in dogs, the incidence of adverse events is actually higher for people that give it intermittently, PRN, than when it's given regularly. And of course, the study doesn't evaluate why that is, but my thought process was when we have this systemic inflammation that we know osteoarthritis causes, I wonder if that predisposes patients to those adverse events, then controlling the symptoms, they actually do better. Obviously, they need to be used judiciously, and dogs are at greater risk for side effects than people are in general for some of the long-term side effects. But we don't have these things over the counter. They're always prescription. In dogs and cats, we have to give NSAIDs as a prescription. But I do find that with judicious use, they're quite safe long-term. So I agree with Kristin. I try to encourage my patients, especially when they have advanced OA and they're experiencing pain and the maladaptive pain and all of the cascade of problems that occurs from not appropriately treating that pain, the benefit far outweighs the risk, I think, if you're using it judiciously and you're monitoring for those adverse effects.
Yeah, and there were a couple studies. One was with Rimadyl and one with Previcox, I believe, that looked at, one was 3 months, one was 12 months. And the dogs actually got better and better and better the longer that they were on it. So efficacy just continued to improve.
Yeah, exactly. And I love Dr. Hooper. I spoke yesterday on joint supplements, and I was like biting, like, what is she going to say about glucosamine and chondroitin? And it's just, I think people want to give something that's natural. They don't want something with side effects, but the evidence is just not there. So I don't know what Dr. Shaw recommends, but I'm just like you. I say, you know what? There's no, you're not going to cause harm. It's well tolerated. So if you feel your pet is getting better on glucosamine, chondroitin, by all means, give it. But the evidence is just not there.
For sure.
Yeah. I'm not currently recommending any glucosamine chondroitin products. I think if we don't make a recommendation for a supplement, our clients are going to find something on their own. And so, Leilani, just like you talk about, just the safety first. And so giving them guidance on which products we would at least recommend from a safety standpoint. That's my take on supplements.
Yeah.
Dr. Hooper, one question from the audience, which I had the same question from Tuesday's talk on regenerative medicine, is the studies that you show, and I was familiar with that the evidence is not there for PRP and treatment of osteoarthritis in humans. Interestingly, on the veterinary literature, we have the highest level of evidence for PRP in the treatment and stem cells in the treatment of OA, as opposed to other conditions. Yeah. And Dr. Knapp, who's a veterinarian, suggested that one possible reason why there's a difference in the evidence is a series of injections. So I don't know if you know, in that systematic review, were those single injections or are they doing a series of injections?
So that's, I think, actually is kind of part of the problem with the whole thing, and why we can't really make a recommendation based on it is because yes is the answer. They're a series. Sometimes some of them are just giving one shot, and it's just really all over the place. And there's editorials that get written quite frequently about how the big problem is that there's no standardization with any of this in the human treatment. So I mean, it seems logically to me that a series of injections would work more effectively than just a one shot. But yes, we need to catch up to our vet colleagues. It seems like you guys have it much more standardized and figured out.
I don't know that that's true. When we have 2 or 3 studies supporting something, that is like great evidence, and you guys are like, oh, I mean, that's just not enough evidence. So
I don't think we have a single meta-analysis.
Yeah. I know, exactly. So let's see. Please, if you have questions for each other, I'm going to start delving into some of these. We had a lot of questions. So
one question I had actually is, I guess for both of you, is that I'm very impressed with how much buy-in you get from your, pet owners, I guess clients is the right word, for doing all these lifestyle modifications, which is so hard for me to get people to want to do that. I just want to feel better. I just want to feel better right now. Can't you fix that? So how do you get them to buy in so well?
I would say that most people, because many people now don't have insurance. Well, more and more people are getting insurance, but most people are paying out of pocket for hip replacements during any sort of surgery. So they're doing everything that they can to avoid surgery. But I don't want to give you a false impression. Not every client is going to do this. So there's many clients out there that won't cover their hardwood floors. And I gave you the example of like the star client. But I think we do probably get buy-in from the standpoint that people are trying to do everything they can to avoid surgery. The thing that they don't want to do most, I see, is change the dog's play. So they don't want to take dogs away from playing fetch and going to the dog park. And that's always a difficult conversation.
For sure.
Yeah, I was gonna say there were actually even comments, Kristin, in the chat about like
I want that house. Yeah, I want that house.
So I would agree. That's like the elite client that's willing to do that.
Yeah.
One thing that I would say, Jessica, that is a big issue that we have for our patients is the lack of recognition that their pet is overweight. I think, I would imagine most of your patients, like they know they're overweight, and it's probably a difficult conversation, but I get clients every day that are shocked when I tell them their pet is overweight. And I tell them, I'm like, when you're like waiting at the grocery store and there's a magazine and you see a human model, you in a swimsuit, you can see their ribs, and that's attractive. They're thin and that's attractive. But whenever you see an advertisement of a dog, a puppy, they're always chubby. And that's attractive, is a chubby dog. And so I loved how both of you spoke about client education being so important, because I truly think that a major problem is education. They just don't understand. And I really loved how your talk really supported what Dr. Andrew said. We had Dr. Andrew on Monday speaking with Dr. Walkschlag about obesity management. And it really, she made a big point to say that 5 to 10% weight loss, just that little bit, makes a tremendous difference in pain management. That was a really good point for me, because I think I'm always looking for that, just like Kristin said, I'm looking for a BCS of 4 out of 9. I want them skinny. But just that little bit of weight loss, maybe they're still overweight, but they've lost a little bit of weight, can make a huge difference.
For sure.
One question, Kristin, which I think I know the answer in case you don't know the detail from the paper, because when people ask me questions about a paper I quote, I'm like, oh no, I may not know this answer, but it was about the study where the single hydrotherapy session made an improvement in range of motion in the elbows. And the question was, did they have more range of motion after swimming compared to after regular physical therapy, or just compared to no therapy at all?
So correct me if I'm wrong, Leilani, but the way I remember it is they measured they didn't compare it to physical therapy. They compared it to before swimming and after swimming. And so it was really just, they took the measurement, swam the dog, then took the measurement again. And that was what they were looking at.
Yeah, exactly. I will fully admit I pulled the paper up so that I was right, but that's correct. Yeah. So it was literally looking at pre-swimming versus post-swimming. So just a single swimming, which is amazing to me. And then the other point is that range of motion was greater in the dogs that had elbow dysplasia than normal dogs. So it's even more beneficial in the dog that is suffering from elbow dysplasia. So I found that astounding. I think it's a great way for us to promote rehab to our clients, is just a single therapy can actually have a substantial difference, which is.
Well, somebody needs to do the same study, and I don't know, maybe we'll do it. But somebody needs to do the same thing with hydrotherapy, with underwater treadmill, because I don't think we can extrapolate them at all.
No, agreed. And I mean, and we know there's more range of motion in swimming than just walking. So, but yeah. Another great question: what is the best way to figure out how high the food bowl should be? I think this was where you were. Yeah. And level, point with the shoulder, or different?
So what I look for is it just a neutral spine. So the just kind of looking at the spine. I think the level of the shoulder is probably a good idea, but I'm just kind of looking at the spine. And this is completely non-evidence based. I have nothing to support this other than it makes sense to me.
No, I agree.
My own dog.
I agree.
Yeah.
Do you use Cartrophin injections, PPS?
So Cartrophin or Pentacin, it's not the same, but I think it's the closest thing we can compare to is Adequan. And in the US, we don't have Pentacin available. So I don't personally use it. I use Adequan, which is the closest thing that we have. So I assume that whoever asked that question is from Canada or the UK or Australia, New Zealand. So if I were you in your country, then I would use Cartrophin instead of Adequan for sure.
Dr. Hooper, there were 2 shout outs for your awesome cat.
Oh, thank you. Yes, he's a big lab cat.
We already talked about the PRP and multiple injections. Okay. Dr. Hooper, how often do you see hypertension associated with NSAID reaction?
I have not seen it that NSAIDs cause hypertension. So in someone who doesn't have it already, I do think that NSAIDs can make it more difficult to control. But usually I only see that if patients are, saying like, oh, I take 1,000 milligrams 3 times a day, and I've been doing that for whatever, 6 years or a long period of time. Or if they also just in general are kind of in a poorer state of overall health. So kind of echoing what we said earlier, I think for the vast majority of people, even with people with well-controlled hypertension, I feel comfortable having them take a daily NSAID or twice a day if Celebrex works better for them, or, whatever.
That's good to hear. Are either of you suggesting the use of CBD oil for pain management?
Well, I practice in Northern California, so I have a lot of patients who do use CBD or, both drops or creams, or also, edibles and that kind of stuff. And I think it's great. I personally don't have the knowledge to say like, you should take this much and this is how much is likely to be effective for your pain. But I think it's, certainly no worse than to get prescribed me someone oxycodone. So I'm all for it if they think it helps them.
Yeah. So I practice in Seattle, so very similar demographic. And I don't know, I haven't done the statistic, but my guess is 90% of my patients come in already taking some form of CBD. So similar to any supplements, I feel like it's our job to counsel the clients on safety first. And so I'll usually say, okay, that's great. Have you gotten a certificate of analysis for the product they're giving? And their eyes get wide and they're like, I have no idea what a COA is. And so at that point, they're like, oh, is there a product you could recommend? And right now I'm recommending Elevet because it is the one that has the most research to support it in dogs with OA. So yeah, I would say I do discuss it and talk about, and I give it to my own dog.
I always laugh because if during a consultation for OA, if I ever recommend CBD, I don't think a client has ever said, no, isn't that dangerous? I don't want it.
Yeah.
Like, always an enthusiastic, I'm so glad you're recommending that.
Yeah. Yeah.
Interesting question here. I think probably both of you can answer it. It says, I'm sorry, but I joined late while driving home from work. Can you explain how OA causes systemic inflammation?
I don't know if that may have come from my slide, and I don't necessarily think it causes. I think it's part of a whole systemic inflammatory process that we know from fat is the largest inflammatory organ, and so the inflammation that comes along with the adipokines, but also the gut. So just gut health and kind of inflammation in the gut can be related back to inflammation in the joint. So it's not necessarily you get arthritis in your, let's say, an elbow in a dog, and it causes systemic inflammation in the rest of the dog. It's believed to be part of a greater systemic inflammatory response. And so, Jessica, what do you think about that?
Yeah, I would agree. One of the big gaping holes, I think, in medical education is nutrition. I'm not that far out of school, and I literally had no education on nutrition and anti-inflammatory diets and recommending any of that for patients. So, in my own life and with family members too, that have kind of gotten into doing changing diets and food remedies sort of for inflammation. I think it's real, and I think it does work. So with helping joint pain. So yeah, I do think it's part of the overall inflammatory picture.
Thank you. Yeah, I think it's great explanation. Let's see. On the veterinary side, we use Adequan on a regular basis. What about on the human side? So that's a polysulfated glucosamine injectable.
No, we do not have that approved for humans, unfortunately.
We love it.
I know it sounds
originally, my understanding of it was originally developed for humans, but because it was an intramuscular injection, it would cause a hematoma, and people didn't like that, and the human side moved more to intra-articular injections, and it kind of didn't use it anymore.
Yeah, I know, it's too bad.
It says it's easier not to feed the dog than it is to not feed yourself. So dog diets are a little easier.
Probably true.
How much do you worry about people who drink alcohol and take NSAIDs? I think the issue would be more Tylenol, no?
Yeah. Yes, I guess. Yeah, because NSAIDs are, metabolized by the kidneys. So I don't, really condone excess alcohol for any of my patients, but I do worry about that more if they're taking a lot of Tylenol. I guess, there is a slight increase in bleeding risk. So if someone is drinking a lot and falls down, there's always a potential for other kinds of bleeding complications if they're already taking a lot of NSAIDs. So in general, people who drink a lot make me worry for lots of reasons, though.
We don't have that issue.
True.
Kristin, I believe this question is for you. Which weight loss diet have you been most successful with for canines?
So I would say that I've been most successful with is actually using fresh cooked veterinary formulated food. So we out here, we have Just Food for Dogs, which is a veterinary formulated whole cooked complete and balanced diet. And that has been, I've had this project dog that I've been working on for years, trying to get her to lose weight. And we tried metabolic and mobility, which tends to be my first go-to, it historically has been. And she just couldn't lose weight. And we switched her over to a fresh whole cooked food, which I think you get all of the crap out, all of this, the additives, and the weight just started coming off. So that's been the best one for me. So that's a Just Food for Dogs. It could be a home cooked diet that is properly formulated, but I think that's going to be the best option if possible.
That's so interesting to hear you say that. I wonder if it's a demographic too. I get a lot of clients that prefer a home cooked diet, and it's good to hear your success with that.
Yeah. And this one, so Just Food for Dogs, I don't know if it's out on the East Coast yet, but it's actually cooked. The clients can cook it at home and get the recipe, or you can just buy the pre-made stuff, which is
We have a kitchen in Union Square,
Okay.
but most of the diets you have to order. They arrive frozen, and you have to thaw
Yeah.
them. But I love that company has, I think, 8 veterinarians on staff, and
Yeah.
it's just unheard of to have that much. And they've actually done clinical trials, which is
Oh, yeah.
great.
Yeah.
It's okay. I recently heard that an elevated food bowl could lead to GDV. Is that true?
That gosh, back when I was a surgery resident, this is 15 years ago, I think, when there were these studies coming out like you should raise the food bowl to decrease GDV. Oh no, you should lower the food bowl to decrease GDV. And neither of them turned out to decrease the risk or increase the risk of GDV. So there's very few things, at least the last that I looked into, very few things that actually increase risk. And most of them had to do with the first 3 ingredients on the food, and whether there was a relative of the dog that had a GDV or they had anxiety. So I don't know, Leilani, do you know anything different working in a big emergency hospital?
Um, I mean, I used to do emergency medicine, and I did not know that an elevated food bowl was associated with the GDV. Jessica, that's a gastric dilatation volvulus, which we see in dogs that are deep. You're like, what's GDV?
Looking it up, you know.
Yeah, so I know that that's not true, I guess, in clinical
So
practice.
yeah, I would say no, there has not been a cause and effect shown with elevating the food bowl.
Yeah. How soon after Adequan injections can one expect to see change, and how long can we expect the treatment to benefit our 12-year-old sweet golden?
So I expect the changes. I usually think it's going to take a couple weeks. So you do twice a week for 4 weeks as this kind of loading dose. The product gets to the joint quite quickly. And the way that it works is it inhibits some of these matrix metalloproteinases, which I think of as little Pac-Men eating away the cartilage. So it's blocking the degeneration part of the arthritic process. And by blocking degeneration, it's thereby blocking, or it's influencing inflammation, so decreasing inflammation. But I think it takes some time to really start seeing the effects of it. So I tell people we've got to do the first month loading dose, and I think it takes about that amount of time. Meilani, I'm curious to hear what you think. And how long to benefit your dog, your sweet golden. Honestly, I would keep your dog on it, or if it were my client, I would keep them on it long term. Now, this is always a question that comes up is, well, what do you do after that loading dose? I tend to go twice a week for 4 weeks, then once a week for 4 weeks, and then have clients go every other week and trying to get about once a month, but looking for return of symptoms. So are they stiff when they get up? Are there changes in their behavior? So some of the things that they identified initially as symptoms, if they're getting worse. So some people will give it once a month, some people will give it every other week, have some people giving it once a week. So for your golden, I would think it would benefit. I would hope it would benefit for long term. It depends how severe the OA is, I think, though.
Yeah, it's so interesting. I think there's quite a few protocols out there for the use of Adequan.
Yeah.
I will say that we had the company come out and give a talk to us, and they were pretty adamant about following the FDA labeling, which was to do the twice weekly for 4 weeks and then just wait.
That's because they have to. So they are under. So I'm a consultant for the company, and yeah. Whenever you have the reps come in, their hands are tied. They are literally only allowed to talk to the label. So they can't recommend anything beyond that. So that it's a shame. It's a shame we don't have any more studies beyond that, because I think it's impractical to say, all right, well, we're going to repeat this whole thing every other month, versus having some sort of timeline. They're also going to insist that you give it IM because they have to. And I definitely disagree with that.
Yeah. Yeah, I think we all see benefits sub-Q. Well, here you go, Dr. Hooper. I don't know that this is good evidence for you, but it says, one of our participants says, I know 3 equine veterinarians who have used Adequan IM for themselves and reported that it was great. So.
All right, good to know.
So you have a patient that wants, a total knee replacement, maybe they can try Adequan first.
Yeah, right. I'll send them to their local equine vet.
That's right. Just make sure you don't recommend that. That's interesting, though. Okay, I have some clients asking about Summit. Any experience or thoughts for dogs?
What is that?
I don't know. Summit. Summit. Are you familiar with that, Dr. Hooper? I don't know what that is.
I haven't heard of that.
Okay. All right. I think Nina Prill, tell us what Summit is, because none of us know. And Just Food for Dogs is available in New York City too. Yes, they have distribution through Petco. Yes, I knew that as well. Yeah, and they actually have a kitchen in Union Square. If you give Adequan monthly and are no longer seeing a benefit, would you restart the loading dose or just increase the frequency?
I've done both. If the dog is significantly more lame or more painful, I will often redo the loading dose. I'm probably also looking at the other treatments or medications that they're on, but often I'll restart the loading dose and then do that taper down to see where they can kind of fit on that as needed basis.
Yeah, great. Let's see, I think, okay, per Summit's website, Summit Joint Performance is the purest form of chondroitin 4-sulfate ever developed. Of course. It is naturally derived and has a low molecular weight, making it extremely effective. Get a free baseball hat. Join online.
Thanks, Dan.
Sounds like we should all try it.
Yeah. Leilani, I think that question's for you.
Oh.
Well, the joint supplement. I haven't used it.
If that's for me. I have never heard of it. I've not used it. And
Yeah.
based on their website, I don't trust it. Okay, I think last one, chondroitin sulfate, equine product, but they are putting it out. They're putting out a canine product now. Oh, okay. Yeah.
Well, wasn't it that of all of the supplements, if I remember correctly from last night, that chondroitin alone had some of the lowest evidence?
That's
And
correct.
you have to combine it with glucosamine if you're even going to expect to have any effect with it.
That's correct. Yeah. All right, guys, it is now 8:34. I can't thank both of you enough. This was so much fun. I really enjoyed learning from both of you so much. Thanks again to PulseVet for sponsoring the talk this evening. And I want to really encourage you all to come. We save some of our best speakers for tomorrow, Dr. Chris Zink, who I highly respect, alongside an HSS specialist, Dr. Catherine McKelney, who will be speaking on prevention of injuries.